So the next speaker is Dr. Adam Brown, who I know well from the Cleveland Clinic, and it's been really interesting. He started out with us as a fellow, so I got to know him for a long time. And you know, when they're fellows, they're like stem cells. You don't know if which way they're gonna grow. And Adam has completely exceeded our expectations. He is a great storyteller. I'm sure you're gonna talk about ruminations, and so he's part of a podcast series as well as one of our great social media champions here. So I'm so excited to introduce him, and he's going to talk about SAPHO.
Great. Thanks, everybody. I'm excited about talking about SAPHO. I think it's a very strange condition, and we don't really know where it lives, which I'm going to kind of focus on. But I think we should all start with all together going through what each of these letters stands for. Ready? Most people get to the first three, then the H and O gets a little tricky. But so we'll go through them, okay? So what is hold on. Oh, each of these are a different slide, apparently. Okay. Consult for Amgen. All right. So outline. So what is SAPHO? How do we define it? I'm going to go through all the letters of the acronym. Okay. How does it present? What are the skin manifestations? What are the joint manifestations? And I'm going to end with some interesting data on what it is. So I think a lot of people kind of associate it with spondyloarthritis, and I'll kind of highlight kind of throughout the talk why that is, why people think it lives in the spondyloarthritis, but it's pretty debatable. Then I'm going to talk about some of the data people think it might have been a primarily infectious-driven disease, and then I'm going to end with some of the data on autoinflammatory and how it could live in autoinflammatory. I remember when I read that, when I was digging through SPA, I gave a two-part talk on Ruminations podcast, and I was digging through all the old literature, and I was kind of surprised by how certain people think that SAPHO is an autoinflammatory disease. And I was like, oh, that's interesting. So I'm going to kind of walk through some of the history of why people think that is. And then at the end, what can we do about it? So synovitis, acne, and pustulosis. So let's start with the synovitis. So in rheumatology, we talk about synovitis a lot, right? But SAPHO syndrome is a little bit unique. It primarily loves the chest, anterior chest wall, particularly the subclavian. And it causes swelling, pain, stiffness and swelling of the chest, usually unilateral. And it also likes axial involvement, which I'll kind of go through some of the data. So when I say axial involvement, people say, oh, it sounds a whole lot like spondyloarthritis. So that's kind of where it initially got the moniker associated with spondyloarthritis, because about 30% of patients had some evidence of sacroiliitis. So the interesting thing about SAPHO is it doesn't seem to like the peripheral as much. So it tends to like this inflammation of the synovium and the sternoclavicular joint, and not a whole lot of literature on peripheral involvement, like the hands, ankles, elbows, and wrists, for example. It doesn't seem to be involved quite as much. So in most of the data, looking at the joint involvement, again, by far and away, it's sternoclavicular involvement or chest involvement. And historically looking at SAPHO, that was probably the first thing that was picked up and how unique this is. So Dr. Tietz was a German physician during World War I, and he's the first person to describe kind of unilateral chest swelling in patients. And he described 4 cases of unilateral chest swelling. And Dr. Tietz was important, really recognized, and he was able to differentiate it from the much more common costochondritis. Right? People say, oh, if you have chest wall pain, it's probably costochondritis. But Dr. Tietz recognized, well, it's not really costochondritis because there's visible swelling in the area and it's unilateral. So he thought it was something different. And Dr. Tietz actually thought it was related to tuberculosis because 2 of his patients had a prior history of tuberculosis. So Tietz syndrome kind of went on for decades as its own unique thing. But this also highlights one of the important aspects of SAPHO syndrome is all the manifestations and all the letters of the acronym can kind of be seen by themselves. So they don't necessarily need to be seen in SAPHO syndrome. For example, sternoclavicular involvement can be seen in a septic joint. It can be seen in primary bone malignancy, and it can be seen in crystalline disease. So just because there's swelling of the chest doesn't mean it's automatically SAPHO or into that diagnosis. So the next thing we talk about is the skin manifestations are really important, which can often drive the disease and often importantly precede the joint manifestations. And again, the skin manifestations can just be by themselves and not related to SAPHO syndrome. So that's why it gets more and more confusing on when to call a patient SAPHO or not. So acne, so the acne is usually pretty severe. often in the face and often presenting for years prior to the diagnosis of, well, the diagnosis is often made when the patient has acne for multiple years and then presents with sternoclavicular involvement or secret ileitis, for example, which can kind of help push the diagnosis forward. So again, acne is not uncommon, right? But the acne in Sappho tends to be pretty severe. They kind of lump it with what's called acne fulminans. And then we have the pustulosis. So the palmar plantar pustulosis can be pretty awful. The patients can have these sterile kind of lumps and masses on their hands that can be very painful. They also exhibit the Koebner phenomenon, where if they touch something or grab something, it actually can worsen the symptoms and cause more pain. So walking can be painful, grabbing something can be painful. So it's really it's an extremely uncomfortable situation. And again, palmar plantar pustulosis can be seen just palmar plantar pustulosis without joint manifestations. There's actually some debate in the dermatology world whether or not palmar plantar pustulosis lives within the psoriasis spectrum of disease. Again, pointing to how Sappho was originally thought to maybe be spondyloarthritis-like or on the spectrum. So other skin manifestations that can occur and are pretty well documented in patients with Sappho syndrome are psoriasis. About 13% of patients can have psoriasis. And hidradenitis suppurativa is kind of well described in patients with Sappho syndrome as well. So there's a lot of overlap here. So hyperostosis and osteitis, okay? So let's start with osteitis. So osteitis is inflammation within the bones. So in Sappho syndrome, it likes to, again, the sternoclavicular involvement. MRI can show T2 hyperintensity that looks a lot like osteomyelitis. So some of these patients are considered to have chronic recurrent multifocal osteomyelitis, or CRMO. And so CRMO in adults seems to be in the Sappho spectrum, and CRMO in kids seems to be a different spectrum. They present differently. CRMO in kids is a lot related to an autoinflammatory condition that likes the long bones. And CRMO in adults seems like a different area, in particular Sappho with the sternoclavicular involvement. So osteitis, again, isn't unique to Sappho, right? A lot of different inflammatory conditions can cause osteitis. If you get an MRI of a patient with rheumatoid arthritis in their hands, they can have bone marrow edema. So hyperostosis, that's a little bit different. So hyperostosis is a reactive bone growth in different areas where the patient's having pain. Again, the sternoclavicular is most predominant. So you can see a good example of that is this CT scan here with that kind of bony overgrowth in one of the ribs. So the hyperostosis can be pretty pronounced. Importantly, I think that what's not recognized is the hyperostosis often takes a while for it to develop. So sometimes a patient can kind of have swelling and pain in one of the joints of the chest. An X-ray is done, and the X-ray may be normal. So they say, oh, it's probably not Sappho syndrome. There's no hyperostosis. But again, it's kind of an evolving field, and we see that all the time in our various diseases like rheumatoid arthritis, where early on the patient may have no erosion seen. So hyperostosis is often a late manifestation, and historically it's kind of important, which I'll get to in a minute, of why we call it Sappho and not Sonozaki syndrome. That'll make sense in a minute. Okay, so that's the bone manifestation, the H and the O. Okay? So this is kind of overall looking at multiple, somewhat larger trials of patients with Sappho syndrome. One of the larger from a number standpoint is coming out of France with 120 patients, and this is looking at anterior chest wall involvement. 63% of patients in that cohort, 73% in another cohort from France, and then 70% from Italy. And then look at the sacral ileitis. So 40% from the France group and 27% from a smaller French group. And then cutaneous manifestations is 84%. So they're pretty high. And again, anterior chest wall seems to be by far and away the most common articular manifestation of the condition. So another important thing to note here is that HLA-B27 positivity. So that's at the bottom of the slide, looking at all larger cohorts. And this is variable between different countries. In Japan, for example, where Sappho was kind of described early, very, very low levels of HLA-B27 positivity with Sappho. But again, Japan has already had kind of a low level of HLA-B27 positivity even in spondyloarthritis. But in the French group, it was 13 to 18%. In the Italian group, HLA-B27 positivity was only 4% of patients with Sappho syndrome. So there's clearly there's not this overarching major association with HLA-B27, which is kind of one of the initial things that, hey, maybe this isn't quite spondyloarthritis, as we would kind of expect on a higher association with HLA-B27. And there's some other differences which I'll highlight as well. So I don't have time to go through all this. When I originally made this talk, I was like, oh, I'm going to go through the history of how all the puzzle pieces came together and who described SAPHO over the decades. Then I practiced it, and it was like 45 minutes. I'll probably get a hook and thrown off the stage. So I'm not going to go through all the different parts of it. But I think that Dr. Tietz's paper is 1921 at the top left. But it kind of shows the work it took to kind of start recognizing this as a unique syndrome. And it took decades of work with these small puzzle pieces coming together over time. Dr. Tietz recognizing the swelling of the sternoclavicular joint. And then in 1961, there was that recognition that sometimes patients with bad acne can have an inflammatory arthritis. And then the Japanese article in 1968 looked at patients who they thought had osteomyelitis, who had also had palmar plantar pustulosis. So in that particular article, the physicians were concerned about a primary infection in the palms, kind of going bacteremic and then landing and causing a septic joint in the sternoclavicular area. So that in this patient, they actually had the clavicles taken out, surgically removed, and the palmar plantar pustulosis improved. So the conclusion was that there was some infectious driver, and they're able to get rid of it by taking out the clavicle. So this is kind of an important point about the history of this disease, and what I guess I wouldn't have appreciated before is a lot of time these patients had sternoclavicular swelling and pain, and they may have had an X-ray, or they may have had an MRI, and the MRI showed hyperintensity. There's not a whole lot you could tell that you can't say that this patient doesn't have osteomyelitis in that area based on the appearance of the MRI or radiographs. So a lot of these patients actually have surgical removal, or they had biopsies to make sure it wasn't a tumor. So now we're a whole lot less likely to do that if we recognize these patients as having this actual syndrome. If someone comes in with big swollen sternoclavicular joint, they also have a history of acne and palmar plantar pustulosis, say, oh, that's actually probably a SAPHO, and there's not this underlying malignancy in his chest. As we can see through the decades, a lot of these patients had their clavicles taken out because they thought it might be underlying malignancy. So then in 1971, we get the description of hyperostosis, and that was again recognized with inflammatory arthritis. So I won't have time to go to that one. So it was finally called SAPHO syndrome in 1989 when a French group came out. And the way they did this, they had 85 patients. And the way they did this was they said, well, we have these patients with sternoclavicular involvement or chest involvement. They have acne and and they have pustulosis in the hands. I wonder how common this is. So they actually sent out, Dr. Chameau actually sent out letters to all the different physicians around France asking them, have you seen this before? And all these letters came back, and was actually able to accrue 85 patients that way. Can you imagine doing that these days? I mean, it's kind of incredible. So he wrote down these observations, and at the end of this article, at the end of this paper, this first paper, he ends it with, there's a loose but undeniable relationship with ankylosing spondylitis and seronegative spondyloarthritis. So he's clearly said there's something else going on here. Some of these patients have psoriasis. Some of these patients have axial involvement. They have sacral iliitis. Importantly, also noted early on, is a lot of patients have unilateral sacral iliitis and SAPHO syndrome. And they're arguing that that's how you tell the difference between SAPHO doing it versus ankylosing spondylitis, which happens to be bilateral. But I don't think that holds up that well. I think there's plenty of patients with SAPHO syndrome who have bilateral, but there is a decent amount who have unilateral sacral iliitis and SAPHO syndrome. So the reason that's the first time that all the puzzle pieces really kind of came together. But I argue that Dr. Sonozaki, a Japanese dermatologist, did it first in 1981. He was a dermatologist and was actually kind of taking notes on all the patients who came to see him in this hospital who had palmar plantar pustulosis. And he recognized that 12 of these patients out of 120 had sternal involvement. So he also recognized a lot of these patients that had axial involvement as well. So he pretty much described SAPHO syndrome. The only thing he didn't get is hyperostosis. So there's actually literally not, there's some recent articles still using the term Sonozaki syndrome to denote SAPHO syndrome without hyperostosis. But it's all the same spectrum of disease, probably just didn't capture it early enough where the patient hadn't developed a bony overgrowth in the area. So what is the driver of Sappho syndrome? So I've been kind of harping on spondyloarthritis this entire time. They have underlying psoriasis sometimes. They have sometimes with hidradenitis suppurativa. They have axial involvement, as I mentioned before. There's some other things that don't quite, and they also have ankylosis sometimes with hyperostosis and ankylosis of the joint, which kind of looks like spondyloarthritis. So it's understandable why people jump to the SPA association. What I've shown is there's not a whole lot of HLA-B27 positivity in the Sappho group. Also, there's other things missing. Not many patients have iritis. Not many patients have inflammatory bowel disease in Sappho syndrome. So there's some differences. So now I'm going to kind of go through what else could be driving this. Infectious. In rheumatology, we've always been kind of obsessed with trying to find some infectious organism that's triggering our diseases. So I'm going to talk a little bit about that. What about autoinflammatory? So I'll end with some of the discussion on autoinflammatory, which I think is pretty interesting. So infectious, this is a very scientific slide, okay? So, you might say, so a lot of these patients had, cultures of their skin, and they had, who with Sappho syndrome, and they had Propionibacter acnes. I'm like, well, that's not too surprising. They had severe acne. But the reason people thought it could be infectious is because when they had, a lot of these patients, again, as I mentioned, historically had bone marrow biopsies when they weren't sure whether this is Sappho is its own autoimmune entity. And a decent chunk early on in the 70s and 80s had actually cultural positive Propionibacter acnes in the bone marrow, in the bone biopsy. So people were thinking maybe this could be some sort of response, an over-response from a primary infection. It didn't really play out over time, though. The more bone biopsies that were done, it was not very consistently positive. And there's sometimes positive with strep, sometimes it's positive with staph. So it wasn't not consistently positive with Propionibacter acnes. Importantly, there's plenty of case reports actually using doxycycline as an antibiotic to try and treat the infection, and it didn't really play out too well. So I think the infectious or the primary infectious driven by that is probably not the case. So what about autoinflammatory? So this goes back as, like, how did they think that Sappho could be autoinflammatory? We think of, autoinflammatory as being inflammasome driven, like the inflammasome, which releases caspase, which cleaves IL-1, and IL-1 is released, and it's an IL-1 driven disease. We often associate with high fevers, and then respond, and then totally the inflammatory response goes away, and the patient feels well. Then again, spiking high fevers. We think of it from the Mediterranean fever, adult onset stills, for example. So I was wondering, well, Sappho doesn't sound like that. Well, the story of why people thought it might be autoinflammatory starts in 1987. So in 1987, Mayo Clinic was evaluating a family, and they started with a middle-aged guy who had a history of severe pyoderma gangrenosum and acne, and he also had a history of really severe pyogenic arthritis. Well, they described it as pyogenic arthritis, but what happened was the patient had huge swelling of his elbow. It would get drained, and cultures would be negative, but the patient actually had destructive arthritis in his elbow, his hip, and his knee, starting at age like 4, and he had these episodes of severe swelling, severe pain. The physicians said, okay, they recognized it in multiple family members of this guy, and they found that as an autosomal dominant disease, and they actually called it pyogenic sterile arthritis, pyoderma gangrenosum, and acne, or the Papa syndrome. Okay? So soon after this description of the family, the gene was discovered, and it's called PST-PIP1. So what is PST-PIP1? I don't know exactly, but I do know PST-PIP1, it binds, the product of PST-PIP1 binds to pyrin. Okay? And pyrin is one of the inflammasomes. Right? So the pyrin is most famous for the autoinflammatory disease of familial Mediterranean fever, pyrinopathy. Right? So when they recognized that association with PST-PIP1 and pyrin, they said, oh, this might be IL-1 driven. So they checked serum and high IL-1 in this whole family of patients with Papa syndrome, and they actually used anakinra. They used IL-1 receptor antagonism, and it really halted the disease rapidly. The skin resolved. So again, it's mostly like a phenotypic overlap. We said, well, what is this acne syndrome, right? So they found, once they discovered that gene of PST-PIP1, they started looking further, and they found this huge group of diseases that are very much acne-heavy diseases along with other manifestations. So Papa syndrome has the pyogenic arthritis and pyoderma gangrenosum, but other ones had severe acne, pyoderma gangrenosum, and hidradenitis suppurativa. They call that PASH instead of Papa. So they had fun with the acronyms. But kind of throughout all these syndromes that were PST-PIP1 was severe acne. So they said, well, Sappho has a lot of acne as well. So that's when the first idea was maybe this might be an autoinflammatory condition, because they recognize that autoinflammatory conditions can primarily cause acne. Now, the next puzzle piece is in the right side. The first two images are from a patient with Papa syndrome. The next puzzle piece came on the slide on the right, and that's in neonates. And they found this neonates who presented with severe pyogenic arthritis, big swollen joints, pain, and they had a diffuse rash, and importantly, they had pustulosis throughout the body. So acne in the first one, and then pustulosis in the second one. The difference is a pattern here. Pustulosis in this disease was from kind of throughout the whole body, whereas pustulosis from Sappho syndrome is primarily on the palms and the soles. But again, pustulosis nonetheless. What this syndrome was discovered to be in 2009 was first described was deficiency of interleukin-1 receptor antagonism. So your body, one of the body's natural ways of regulating interleukin-1 is actually has its own endogenous receptor antagonists. So it can release endogenous receptor antagonists, which can block its own IL-1. So it's kind of much more tightly regulated. So in this disease, the children don't have their own endogenous interleukin-1 receptor antagonists. So they have overwhelming amounts of IL-1 activation. And that leads to pustulosis. So again, that has this, so we're getting IL-1 causing acne in this group of syndromes, and we have this IL-1 driven disease causing pustulosis. These kids also had chronic recurrent multifocal osteomyelitis. Okay? So we're getting a lot of this kind of phenotypic overlap with Sappho syndrome, which is where people thought that, hey, maybe there's some sort of, maybe Sappho syndrome is actually IL-1 mediated, which we hadn't really thought of before. So now the big question comes to, well, what do you do about it? Does IL-1 work? So we'll get to that in a minute. So interesting, looking at the papers from the 1990s, looking at kind of long-term outcomes, that French study with 120 patients. So they looked at using NSAIDs, they looked at using bisphosphonates, because again, all these patients had osteitis and hyperostosis. They thought using bisphosphonate could help that. Doxycycline was used, as I mentioned before, because I thought it might be an infectious-driven disease. So I like that the outcome measure was considered, the patient had a really good response if they felt 60% better. So it kind of shows how much better we've gotten at utilizing therapeutics and making patients feel better. Because back then, like 60%, fantastic, you're doing great. So the idea of disability was a little bit different. These patients were followed up quite long, and mostly they did okay. They said there's quote unquote no disabling arthritis in this group of patients with Sappho syndrome. Another study from Italy had 11-year follow-up, again using NSAIDs, glucocorticoids, DMARDs, and IV bisphosphonates, and only 9 patients had TNF inhibitor. And they actually had they recognized that these patients who got TNF inhibitors actually did pretty well. They also, I think importantly, kind of classified that patients had different disease courses. Some patients were monophasic. They had one major flare, and that was it. It resolved completely. Only 13% of patients. The majority of patients don't have that. Most patients have either relapsing remittent or kind of chronic presentation. So one of the recognized risk factors having more chronic presentation was at presentation had high and elevated inflammatory markers. So what have we learned so far since the 90s? Well, since the 90s, there's kind of a potpourri of therapeutics that have been thrown at Sappho with hit or miss results. So this is kind of not one that you're supposed to read, obviously. So the middle is kind of from the 2019 systematic review of biologics, and that's just a list of all the different studies looking at TNF inhibition in Sappho syndrome. And the 2 columns on the right are looking at how much their skin responded versus how much their joint responded. And it's pretty much across the board, like pretty good. Well, some patients respond extremely well to various TNF inhibitors, and some patients have primarily joint response with minimal skin response, or vice versa. So it's a little bit difficult to predict, and we don't have a good handle on what therapeutic works the best for each patient, as we can say with a lot of our diseases. IL-17 has been looked at. They looked at IL-17's role in acne. They looked at IL-17's role in pustulosis, including osteitis. So there's some preclinical data supporting using IL-17 inhibition, and I personally used IL-17 in a patient who failed TNFs, 2 TNFs, and that had responded very well from both the skin and the joint standpoint. So IL-17 has been looked at, IL-23 has recently been looked at, JAK-STAT has been looked at with varying results. I can't say with anything that one works better than the other. I think we have data with a variety of therapeutics, and they seem to work for the most part. Patients do pretty well. It seems like it makes sense to use NSAIDs in mild cases, similar responder arthritis, consider DMARD therapy, and then TNFs probably make the most sense early on, and not because they're the best drug, it's just we have more data on them, which is not surprising since they've been out since the 90s. And then after that, the question mark is, 17 versus 23 versus JAK-STAT, and the answer is we don't know. But back to IL-1. So IL-1 has actually been used only in a small amount of cases, and it worked pretty well. Again, it didn't seem to be like an aha moment where it had like clear results better than TNF inhibition, but there is data looking at IL-1 inhibition, and it seems to work decently well in like 9 patients, so it's not very much. But again, arguing it heralds back to, what is this disease, what's driving it? And the answer is we don't know so much. I'm leaning towards autoinflammatory, but people may disagree with me on how you define autoinflammatory. But we have some data showing IL-1 seems to work, but I don't think that's like the first-line therapy for Sappho syndrome. So in summary, remember, synovitis, acne, pustulosis, hyperostosis, and osteitis. Most common presentation is sternoclavicular joint pain and swelling. It could be acne or pustulosis or both or none. It's confusing. Is it SPA? Is it autoinflammatory? And then there's the various medications that have been tried with variable success. And that's it for my talk. I guess I'll answer questions afterwards. Thanks.
Thank you, Adam. Those were really nice slides, by the way. Next speaker is Dr. Emily Littlejohn. So she's here at the Cleveland Clinic, and she directs our lupus center, and she's going to be talking about emerging therapies.
Thank you, Elaine. Thank you, Len, for having me. Okay, so I'm going to first start with talking about a little bit of background with lupus and where we've come from, the 1800s up to now. But before we do that, let's talk a little bit about the heterogeneity of lupus, which has already been discussed before, and Len alluded to this. The heterogeneity of this disease makes it very difficult for both lupus management and drug development. And this pertains not only to the clinical heterogeneity, but also the immunologic. And as you see here, this outer ring is all the different clinical heterogeneity and manifestations that we see. And the inner ring is the immunologic heterogeneity, so things like the cytokine profiles, the immune complex profiles, the type 1 interferon signature, the type of cytopenias on someone's CBC. So with these two moving parts, there's a lot of permutations as to how patients can present to us clinically when we see them. So before talking about therapies, let's talk about the pathogenic mechanisms. And this is a slide really just to show the overview of the immunologic mechanisms that go into this disease. On the upper left here, we begin with the exposure of antigens, either from apoptotic material, from dying cells, or neutrophil extracellular trapped debris. And these include things like double-stranded DNA, histones, Rho and La, and snRNP. Once we have the exposure of these antigens, we then develop autoantibodies. So these autoantigens are presented to self-reactive T cells, which provide help to B cells, resulting in cellular activation and the production of these pathogenic autoantibodies. Next here, the autoantibodies bind to these autoantigens and walks in immune complex disease. These immune complexes then engage Fc gamma receptors on plasmacytoid dendritic cells, leading to internalization via endocytosis. Moving along, the intracellular toll-like receptors are activated by nucleic acids on the immune complexes, resulting in type 1 interferon production, which is obviously a major part of role of pathogenesis in lupus. The chronic immune activation causes excessive production of pro-inflammatory cytokines, which promotes production of B cell survival cytokines, so things like BLyS or APRIL, and contribute to the activation of T cells and differentiation of monocytes into dendritic cells. And lastly, Many cytokine receptors, including type 1 and 2 interferons, transduce signals using the JAK-STAT pathway. Type 1 receptors activate JAK-STAT to drive transcription of interferon-stimulated genes to create a positive feedback loop for inflammation. So really, when this cycle begins, inflammation continues to ensue. And this slide is really great because it also shows some recent medications and where they intervene. So we'll be coming back to this slide a few different times. So where have we come? Well, up to 2020, there have only really been a few drugs that have been officially approved for lupus. We'll start with the 1800s with quinine. And this was first described in 1894, but anyone who's listened to Adam J. Brown's talk on ruminations or seen his Twitter page know that in the 1950s, during World War II, soldiers were given an anti-malarial, I think it was meprocrin, as an anti-malarial, and they noticed that patients with cutaneous lupus and inflammatory arthritis improved. So it was observation like this and data like these from which hydroxychloroquine was born, and its approval was officially went through in 1958. Aspirin is another officially approved medicine described in 1898, not approved until the 1940s. Of course, corticosteroids. Cyclophosphamide, which was actually approved for nephrotic syndrome if you actually look in the lexicon, and this was in 1999. And then finally, in 2011, we have belimumab for systemic lupus. 2020 is what many of us consider the lupus renaissance. And this is a time when finally we had many drugs that kind of came into our armamentarium very quickly. The first one being belimumab, which is approved in 2020 for lupus nephritis. Voclosporin, which was approved for lupus nephritis in January of 2021. And anifrolumab, which is approved for systemic lupus in 2021. So this is really where we are as of now. We have belimumab, anifrolumab, voclosporin for the many manifestations of lupus, in addition to all of our other medicines, which include the following. Unfortunately, we still have very varied outcomes. We're really not doing very well in terms of how we're treating our patients. There's really no smoking gun or no standard of care for how we treat our patients with an ensured outcome. So I picked 5 emerging therapies, and this is by no means an exhaustive list. This is just based on recent literature that I want to discuss today, and I want to spend some particular time on the last one, the CAR T therapy. Where do these medicines fit into this 30,000-foot view? Well, BIB-059 is litifilimab, interferon kinoid, both of which take place in the interferon pathway. We'll talk about obinutuzumab, which is a B-cell depleting factor, CAR T therapy, and then iberdomide, which is actually not shown on this diagram, but takes place in hematopoietic stem cells. So no talk about lupus is complete without talking about interferon, which Len alluded to early this morning. What we know about interferon is that there are increased levels of interferon in serum of patients with lupus. It's associated with general symptoms of acute viral infections, such as muscle and joint pain, headache, pleurisy, fatigue. And interferon also has a suppressive effect on the bone marrow, resulting in anemia, neutropenia, lymphopenia, and thrombocytopenia. This is often, what we attribute when patients say, "Oh, I feel flu-like," or "I was out in the sun and now I feel like, I'm very fatigued and have fevers," and we can really attribute this to the interferon pathway. We've found that lupus disease activity correlates with interferon levels and the strength of the interferon signature. And there's many inducers, which are shown here on the right, inducers and regulators of the interferon production by plasmacytic dendritic cells. So these are the 2 therapies I'd like to talk about in terms of the interferon pathway. The left one here is litifilimab, and this is a humanized IgG1 monoclonal antibody that targets the blood dendritic cell antigen 2. And you can see here on the left, there's a picture. On the right is the interferon alpha kinoid, and this is a very interesting drug. This is considered an immunotherapeutic vaccine. This is composed of an inactivated interferon alpha to a carrier T helper cell protein that generates endogenous polyclonal antibodies to block interferon. So it's a drug that basically induces antibodies. So in terms of the literature, litifilimab was initially studied in cutaneous lupus patients, a total of 132. And what they found was this medicine was subcutaneous, it was an add-on to standard of care, and it met primary endpoints with a decrease in skin CLASI score at week 16. Now, a subset of these patients I then went on to analyze in terms of active joint disease. There was a total of 102 that were assessed, And this did meet primary endpoints in terms of a decrease in the number of active joints at week 24. In terms of a safety profile, there were 2 cases of herpes zoster and 1 case of herpes keratitis. Now, we didn't have so much luck with interferon alpha kinoid. This medicine received FDA fast track designation in 2016. This was a phase 2 trial that showed promising results. It showed induction of neutralizing antibodies against interferon, a decreased interferon signature, improved fatigue, which I thought was interesting, and reduced corticosteroid dose. So it was found to be steroid sparing. However, it did not meet primary endpoint, which was neutralization of interferon gene signature and BILAG lupus assessment with modified mandatory steroid tapering. So long-term follow-up of this trial was terminated, and the status of the phase 3 trials are currently uncertain. Now we can move on to obinutuzumab, which is a type 2 monoclonal antibody. And so randomized placebo-controlled trials of type 1 anti-CD20 antibodies, which include things like rituximab and ocrelizumab, which we are familiar with, they failed to demonstrate complete renal response in lupus nephritis. This medicine, obinutuzumab, is a humanized type 2 anti-CD20 monoclonal antibody, which provides greater B-cell cytotoxicity and depletion. And the question is, well, why is that? One thought is that type 1 compared to type 2, you see here on the left, type 1 is partially internalized, whereas on the right you see that the type 2 is not. It is completely on the outside of the cell. And this might account for the efficacy that we'll see in type 2. So this is the Nobility trial. And this looked at patients with proliferative lesions of lupus nephritis who were on background mycophenolate mofetil or mycophenolate sodium. There was a total of 125 assessed. And this did meet primary endpoints of complete renal response at week 52 with further improvement at week 104. Complete renal response being a UPCR less than 0.5, no active urine sediment, and a return to baseline of the creatinine. We also found, on the right here, greater improvements from baseline in C3 and C4, double-stranded DNA antibodies, and further improvement of the UPCR at weeks 52 through 104. So keep that in mind for the future. Next is iberdomide, and this medicine is an immunomodulatory IMiD drug. This promotes degradation of transcriptional factors, including Ikaros and Ios, and there's a picture here on the right that you can see, kind of representative of what's going on here, which reduces activity of B cells and type 1 interferon pathways. This medicine is very similar to thalidomide, which is used in multiple myeloma, and like I mentioned before, this takes place in the precursor hematopoietic stem cells. This study had 288 patients, and there was 3 doses that were looked at with this medicine. It excluded patients with thrombotic risk, active neuropsych lupus, or lupus nephritis. These patients were actually very ill, with an average SLEDAI of 9.6. And what was found was that this did meet primary endpoint, which was response by SLE responder index, or SRI-4, at week 24. In terms of safety profiling, there were some accounts of URIs and UTIs, and also neutropenia. Now I want to talk about chimeric antigen, or CAR T-cell therapy, and this is a very exciting space. I want to just really back up and say, what is this therapy? Now, these are living drugs. They're chimeric antigen receptor T cells that are genetically engineered to produce an artificial T cell receptor for immunotherapy. The chimeric antigen receptor is a receptor protein that's been engineered to give T cells a new ability to target a specific antigen. So the receptors are chimeric because they combine both an antigen binding and a T cell activating function into one single receptor. And these are just a few examples of other CAR T-cell therapies. So this is used in the oncology world. We've seen it in ALL, NHL, mantle cell lymphomas. But the question is, well, what about in our diseases? What about things like lupus? And what would that look like? Well, this is the process kind of from soup to nuts on how this happens. So what happens first is that we isolate a patient's leukocytes via leukapheresis and then sort only the T cells, both CD4 and CD8. We transfect the T cells with a coding DNA, a lentivirus vector, to produce a new receptor capable of recognizing a target antigen. In this case, it's CD19. So once binding to this antigen is achieved, the innate signaling can turn on machinery to destroy the cell. This CAR T cell-based therapy can produce a massive immune inflammatory response, which requires obviously inpatient admission for these patients for probably about 2 weeks after they've been reinfused. So let's talk about the study that was done in our lupus patients for CAR T therapy, and this study was done in September of 2022. This was a study that looked at patients who were all meeting EULAR-ACR 2019 criteria, so they're all ANA by FA positive, and had to meet 10 of those criteria. They all had active proliferative lesions, so they had a class 3 or class 4, and they all, interestingly, had multi-organ involvement of heart, lung, or joints. These are very sick patients. Not only did they have lupus nephritis, but they had at least one other organ involved. And they had to fail to respond to multiple therapies, and this is really everything. So pulse glucocorticoids, hydroxychloroquine, belimumab, azathioprine, mycophenolate, cyclophosphamide, and rituximab. Now, orthos are a little bit vague in terms of exclusion. They did mention that they were excluded patients due to concomitant psoriasis. However, they didn't mention that it was a specific exclusion criteria in patients with other autoimmune conditions. None of these 5 patients had any CNS lupus, and there was no specified age criteria, although in this study, patients were only 18 to 24 years old. So these are young patients who are very sick, who had active lupus nephritis and other organ involvement, who would really run the gamut of all of our medications. So these are 5 patients that were enrolled from a single site in Germany in February 2021 to February 2022. There was 1 male and 4 females. Average disease duration was 1 to 9 years. And what is interesting is what was omitted is the creatinine value at baseline, along with a few other baseline demographic information. So here are the 5 patients. You can see the age. They were all around the same age. What is the most interesting, I think, in this slide is the organ involvement. So this patient had skin, kidney, joint, lung, heart, and this is actually Lemon-Sachs endocarditis here. And these are all the medicines that they had been refractory to. Same with patient 2, multi-organ involvement. There's a few patients here who had lung involvement. And when I mentioned this was both restrictive and diffusion deficiencies, they had, one had ILD, and I believe one also had ILD with, I believe, pneumonitis. So these are very sick patients. And here are the results. So first we'll look in the upper left, and we see the circulating CAR T cell numbers. They really exponentially rise after day 10. So you can see that these patients are just being repopulated with these CAR T cells. At the same time, on the right, you see the circulating CD19 B cells drop, and they really reach 0 at day 10. So what about outcomes? Well, you see on the upper right here, the SLEDAI scores in these patients. So at baseline and 3 months, you can see every single patient, the SLEDAI score drastically drops. And what's really interesting about this data is that we also see their fatigue scores drastically drop. So what this tells me is that there's both type 1 lupus symptoms that are being controlled and also type 2, because the SLEDAI score only incorporates inflammatory lupus symptoms. You see here on the bottom left, proteinuria, complement C3, anti-double-stranded DNA antibodies. These all also improve over the 3 months of follow-up. Authors note in this study that nephritis ceased in all 5 patients. Arthritis, fatigue, fibrosis of cardiac valves, like I mentioned, that patient with Lemon-Sachs endocarditis, lung restriction and diffusion impairment disappeared after CAR T therapy, which is incredible. Interferon alpha was undetectable in serum of all the patients, even though it was only detectable in 3 at enrollment. And one of the last mentions in this paper is that all DMARD immunomodulatory drugs, including plaquenil and steroids, were discontinued, putting patients in a drug-free disease remission. So what are some considerations for this therapy? Well, there's a huge risk of cytokine release syndrome, ICANS in particular, which is very scary. So there's a supraphysiologic response following the immunotherapy that activates T cells and other immune effector cells. Symptoms can be progressive. They must include fever, might include hypotension, capillary leak, and organ dysfunction, et cetera, et cetera. This study, and apparently compared to other studies, showed that the risk was much lower than what we see in our malignancy-based CAR T therapy. But again, the numbers are very small, maybe too small to make this statement. So some limitations of this study. Well, it was a limited sample size, just an N of 5. The average month ranged from 5 to 17 months of follow-up. They don't really mention baseline creatinine or improvement of creatinine after the CAR T cell administration. And we don't have any renal biopsy before or after to document histologic changes, which is not necessary, I think, in a lot of our other studies, but it would be nice to know if the lesion actually changed or if it just went into kind of a chronic state. So is this therapy too good to be true? And I think there's a lot of new studies coming out, phase 1 in particular, hopefully to get some more answers. But I think there is a lot of promise in this space, just considering, you know, these 5 patients and how well they did and how sick they started. So that's all I have for you.
So we get an encore with you. Yes. And since Len made a comment about compliments, I guess we get to learn all about them now, even though we didn't at the beginning. Thank you.
Hello again. So a 3:30 on a Saturday discussion about complement. Buckle up. It's exciting, right? So I like having this slide up first. I've been interested in complement for a long time. And when I was a fellow, I did a talk on complement and vasculitis. And the reason I put this slide up first, I like to put up as the underline the E, is because I spent 3 months working on this talk about complement. And Lenny Calabrese was my mentor. And I get ready, I show up really early on the day of the talk, and I'm there with the slide, and I misspelled complement. So he walked up to me and said, "That's really funny." And I was like, "What are you talking about?" He's like, "You didn't spell complement right." And I was like, "Look," I was like, "Oh yeah, ha ha ha." And then he walked back to his seat, and I quickly ran and changed all the things. And I was like, "Oh, that complement has an E in it." When you're giving somebody a compliment, it's an I. So learn something new here. So what is complement vasculitis? This is a really interesting field, right? Because it's changed dramatically over not so long of a time. So prior to the early 2000s, we didn't think vasculitis was driven by complement at all. We didn't think complement had much to do with vasculitis. And why is that? Well, a couple reasons. So if you have someone with vasculitis, a very aggressive vasculitis presenting, causing capillaritis, causing diffuse alveolar hemorrhage, or rapidly progressive glomerulonephritis, and you check their C3 and C4 in their serum, they're typically normal. So in contrast, diseases that we think of like immune-mediated disease like lupus, or immune complex-mediated disease like lupus or cryoglobulitic vasculitis, when you check activity levels, the C3 and the C4 are low. We say, oh, those are, complements doing something there, it's being consumed with active disease. So in ANCA, that wasn't the case. Complements didn't really budge much, maybe a little bit, but not a whole lot. So we said, okay, complements not really driving this disease. Not only that, we had a patient coming in, again, sick, ICU. They have going into renal failure. You get a biopsy of their kidneys, and what do? So we look at it and see, oh, the crescentic glomerulonephritis. How do you differentiate it from other types of crescentic glomerulonephritis? Immunofluorescence can be very helpful, right? We check for IgA, IgG, IgM. We check for the 2 complement, well, there's a lot of complement components, but we typically check for C1q and C3. So in lupus, again, a disease we know complement is doing stuff with, it all lights up. All of it's positive. The whole full house presentation on renal histology. Then other things, you have, if IgA vasculitis, you have IgA lighting up. In good pasture disease, you have a nice, beautiful ribbon of IgG on the renal histology. But what about vasculitis? Not much, right? So you have hardly any staining of anything, and we call it autoimmune glomerulonephritis, that buzzword for vasculitis. So again, not even much complement deposition of the kidneys. So for decades, we're like, oh, complement's not really a major driver of this disease. But not only now do we think complement's important, we think it's a major driver of the disease, and now we're inhibiting it and rapidly reducing the amount of glucocorticoids in the process, something that would probably be unheard of even just a decade ago. So the disclosure one from the last one was like, I consult for Amgen to teach about complement. So here we are. So overview. So overview of the complement system. Data leading to the complement being pursued in vasculitis. Talk about the mouse model of how that really taught us a lot about vasculitis and pursuing complement vasculitis. Then I'm going to get to the human data, and eventually end with some of the data on the advocate trial with complement C5a inhibition. Okay. So let's kind of just start with just an overview of the complement system. So I always say it's the most learned and forgotten system secondary only to the Krebs cycle, right? So it's really, really complicated. It has a lot of letters thrown about that change and bind to other proteins. There's 60 plus proteins synthesized mostly by the liver. We kind of throw out the term that bridges the innate immune system to the humoral immune system, but there's a whole lot more to it than that. It's bacteriolytic. It has components that can kill bacteria. It has components that can kind of tag bacteria, the opsonization, that allow your humoral immune system to kill it better, or innate immune system to kill it better. So the complement system can do a lot of different things, and it gets very complicated when you look at that whole schema of complement, and you see all the different letters and how they combine it. Oh, so I'm not going to memorize this. But it's easier than that. We can make it easier than that. So let's get to it. So this is one of my favorite ways of looking at the complement system, because it gets rid of most of the A's and B's, okay? And it just focuses on the main protein. So I think at this point, what you need to know in terms of the split products that everyone gets confused about is just the split products of C3 and C5. And you can get through most of the time, although there's a ton of complement inhibition work happening with various diseases and various components of the complement system. So that may change in 5 years, where we'll have to learn more and more about the different split products. But for now, C3 and C5 seem to be good ones to memorize. So let's talk about the 3 pathways that we think about with complement activation. We think about the classical pathway, the lectin pathway, and the alternative pathway. So the classical pathway is probably the one we are the most familiar with, because we see it probably activated in some of our diseases, including lupus, including, as I mentioned, cryoglobulinemic vasculitis. So the classical pathway is triggered by immune complexes, meaning the immune antibody is binding to its cognate antigen, or it's even binding to another antibody. So that triggers conformational changes to the Fc portion of the antibody, which allows C1q to bind to it. The first step of the classical pathway is C1. It says C1, but it's C1q. And then that triggers C4, that triggers C2, and eventually now we're into the common pathway with C3, okay? So we'll stop there for a second. So C3 is the first step of the common pathway. So the common pathway is an important point to note, because all 3 of the pathways lead to the common pathway, hence the name common pathway. So once we get to C3, we go to C5, and then it gets a whole lot easier to memorize, so then you go to 6, 7, 8, 9, okay? And 6, 7, 8, 9 actually are proteins that go on the bacteria and punch a hole in the bacteria called the membrane attack complex. So it's a very important part of the complement cascade, and something that we think of often as the reason we have the complement cascade is we want to bind those proteins to bacteria and cause bacteriolysis and kill the bacteria, kill the infection. The membrane attack complex is the important component to do that, and all of those 3 lead to that, okay? So the classical pathway is triggered by immune complexes. The lectin pathway is different, okay? It's triggered kind of like the first lecture from Lenny. The first protein is the MASP, in contrast to the classical pathway, which is C1q. So it's looking for kind of like the PAMPs and DAMPs, right, in the blood. It's looking for things that aren't supposed to be there, and in particular, the lectin pathway is looking for carbohydrate repeats that aren't seen in the human cells. So when the MASP binds to these carbohydrate repeats that aren't supposed to be there, which triggers, again, C4 and C2. So those are the same proteins in the classical pathway. So those, after that first protein, C4 and C2 are the same in both the classical pathway and the lectin pathway. So importantly, the classical pathway and the lectin pathway are both triggered by something. But then we have the alternative pathway, which is very different, aptly named alternative. Okay, so it is an evolutionarily more ancient pathway, and it's very interesting in the fact that it's always on, okay? It doesn't need to be triggered by anything. So people talk about it being the immune system idling, just kind of going. It actually gets triggered by water, which sounds like a really bad idea, right? Water is kind of everywhere. Why would you want your immune system constantly going, okay? So the reason that works this way is because all of your cells have proteins on them that turn it off, okay? So when the alternative pathway is triggered, as with water, it goes, it happens to land on one of your cells. Your cell may have a protein called protein H. Protein H is like, I was thinking of the protein hold on, like hold on, you're not supposed to be here, and it shuts down the alternative pathway. So the alternative pathway is always revving, always kind of idling and going, and your body's turning it off. So in contrast to the classical pathway and the lectin pathway, the alternative pathway does not need to be triggered, okay? And importantly, the alternative pathway has unique proteins in it. And 2 of them would be factor B. The other one is properidin, which isn't on this. Okay? So they all converge onto C3 no matter what the trigger is, okay? So C3, when it gets activated, it splits to C3A and C3B, okay? Then C3B goes on to trigger C5. And C5 splits to C5A and C5B, Remember I mentioned it's important to know the split products of C3 and C5. The reason that is because C5b goes on to bind to C6, which then goes on to 7, 8, 9, and the development of the membrane attack complex. So C3 and C5b are the ones that continue the complement cascade, okay? So what are the A's doing? The A's happen to be potent chemoattractant factors. C5 is actually more potent than C3. So the A's, when they're split and the A's run off to go gather more troops, okay? They're gathering neutrophils, they're gathering macrophages and other innate immune cells to the area of inflammation. So C3a and C5a are doing that. So importantly, they're not part of the continuing cascade of the complement system, okay? So if you blocked the A's, you're no longer blocking the continuation and the development of the membrane attack complex, okay? That's an important thing to note. So highlighting C5, yay, C5a, okay? So now let's get back to ANCA vasculitis. Remember what I talked about before with the autoimmune glomerulonephritis and the renal histology? Well, 2004 study looked at this from Hopkins and they're saying, well, how much autoimmunity is there? Like, is there some more measurable immunofluorescence than we give it credit for autoimmune glomerulonephritis? There must be something else there. So it turns out, upon really looking at it, almost half of them have some IgM component to this, and there's over half have some C3 there. Also, over half of them have on electron microscopy have some electron-dense deposits on renal histology, we think is probably some antibody and some complement deposits, okay? So that says, maybe the humoral system and maybe the complement system is actually doing something here. We don't know how much of a driver it is, though. So how do we figure that out? That's when we have the nice mouse model that can really change this disease and how we think about this disease. So the mouse model, basically, it's a lot more complicated than this probably. This is how I understand it. So the mouse model is a genetically determined mouse that has a predisposition to develop microscopic polyangiitis, okay? Primarily a autoimmune glomerulonephritis when it's triggered. And it's controllable. So the mouse, if you leave it alone, it won't develop microscopic polyangiitis. But if you have that mouse and you inject it with anti-MPO, then a few weeks later on autopsy, the mouse has autoimmune glomerulonephritis looking a whole lot like ANCA vasculitis. So we have that mouse model that has a controlled ability to kind of cause autoimmune glomerulonephritis. So in 2007, some researchers said, well, let's see what the complement system is actually doing in this disease. And yeah, okay. So what they did was they said, okay, if we know we can control and cause autoimmune glomerulonephritis in this mouse model, let's knock out C3, okay? So they did a lot of knockout mouse work, not knockout gene work on a mouse. Anyway, and they were able to say, okay, well, if C3 is needed for the development of ANCA vasculitis, if the mouse doesn't have C3, then they won't develop glomerulonephritis, right? So if they don't have C3 and then you give them anti-MPO, typically we would see develop glomerulonephritis. But if they don't have C3 and then they don't develop glomerulonephritis, that's showing that C3 is needed to develop glomerulonephritis. So what did they do? So they first did a knockout mouse of C3, and voila, no glomerulonephritis. Like, whoa, this is a big deal. We've always been thought that complement wasn't really needed for the development of glomerulonephritis. So I said, well, let's start looking a little further and see what this is, because it doesn't really help, C3 doesn't really help us figure out where it's coming from, because C3 is the first part of the common pathway. All of the different pathways lead to that. So one good way to check next is checking C4. So C4 is in the classical pathway and the lectin pathway. And in rheumatology, we feel a little more comfortable with the classical pathway, so this is probably where it's going to be. You know, we all love the classical pathway. So, next I did C5. So C5 was also necessary for the development of glomerulonephritis. So we have C3, and then we have C5, and we say, okay, now we need to figure out where it's coming from. So then they check out C4. And guess what? When they knocked out C4, it did not stop the development of glomerulonephritis. So without C4, the mouse was still able to develop glomerulonephritis, arguing that C4 does not seem to be necessary for ANCA vasculitis in the mouse model. So I said, oh, wow. So C4 isn't really doing anything. Okay, so that kind of actually takes out the classical pathway and it takes out the lectin pathway. So what's next? The alternative pathway. They knock out factor B and halts the progression of glomerulonephritis in the mouse. Like, oh my God, the alternative pathway. We never talk about the alternative pathway. It's doing something here in ANCA vasculitis. So it's a lot of excitement here. So, so then next they say, okay, well, we have it where it's being triggered and starting in the alternative pathway, going down to the C3, it's going down to C5. We all see where this is going, right? We all see this going down to C6, and it's going to go all the way down to the development of the MAC. We think MAC is really important for bacteriolytic, causes really important for inflammation. That's probably where this is going to go. So what do they check next? They check C6, and boom, voila. C6 doesn't do anything, okay? So like C4, with blocking C6, the mouse still develops glomerulonephritis. So they said, oh wait, so C5 is needed, but C6 is not needed. So what's in between, right? I said, oh, C5 splits to C5a and C5b. So they go after that and they knock out C5a and it totally halts the disease, okay? So that is a split product of C5. So this was an important discovery because they recognize that if you're able to block that, then you don't necessarily block the development of the complement cascade. So the mouse model really helped pave the way to understand of ANCA vasculitis and open the doors to better understand a possible potential therapeutic use for treating ANCA vasculitis. So now I'll go on to the Advocate trial. So the Advocate trial was the phase 3 version of C5a receptor antagonist, okay? So avacopan is the name of the medication. And they're utilizing it, as I mentioned before, so that's blocking C5a receptor, okay? So after that mouse model came out, they started doing human studies also insinuating that C5a is a primary driver of ANCA vasculitis, which led to the development of this medication and utilizing it in phase 1 and phase 2 trials showing efficacy. So that led to the Advocate trial, which is a phase 3 trial of in active ANCA vasculitis. So 331 patients, the primary endpoint was a BVAS of 0 by week 26 with no relapse at week 52. And there's a lot of slides to talk about this, but I kind of summarized it with time to relapse in the avacopan arm versus the prednisone arm. The avacopan arm had longer to relapse, less relapses, and longer to relapse compared to the prednisone group. So the trial was designed that induction was done by either cyclophosphamide or rituximab in both arms of the trial, and then the patients had either high doses of prednisone with prednisone taper over a few months or avacopan. And initially, the trial was no prednisone, but in reality, a lot of these patients got prednisone because of various reasons, which I'm happy to talk about later. But the avacopan patients got dramatically less prednisone compared to the prednisone arm, as you can imagine. So what we'd kind of hope for in ANCA vasculitis is if you're using almost no prednisone, it'd be great if it was somewhat equal to the patients who got prednisone. But it actually showed superiority at week 52 in keeping patients in sustained remission. So it's really exciting because, again, you're keeping patients in sustained remission with almost no steroids. So that's pretty incredible and something we probably never would have guessed that would possibly be possible not that long ago. But it's because we much better understand this at a very specific level what's driving this disease. So this is looking at changes in kidney function in patients who presented with very bad kidney function, and looking at the GFR improvement over time in the avacopan group versus the prednisone group. So in the avacopan group, you actually see improvement over time over the course of 52 weeks, as compared to the prednisone group. But you have some improvement. You can see the avacopan group has actually more improvement over time. And this is something that I think is really important because it kind of shows me where we're going, right? Looking at ANCA vasculitis, we always think about, this is a deadly disease. If you don't treat it, the patient will die, right? So it's an important thing to recognize how serious this disease is. So, not that long ago, you'd have a patient, in the ICU with diffuse alveolar hemorrhage, going on to dialysis, and who may have been felt fine a few weeks before. It could be very dramatic very quickly, and they could deteriorate really rapidly. So we used to give them high doses of steroids, give them rituximab or cyclophosphamide, and then their diffuse alveolar hemorrhage stopped, their renal function got better, and you see them outpatient clinic. A few weeks later, they're feeling better, right? They're still on maybe on 40 milligrams of prednisone at that point, and hey, I'm tired, but I'm alive, right? And they say, hey, look, you have your lungs look a whole lot better. You're not on oxygen anymore. You're not on dialysis. We won, right? We stopped the disease. We saved the life. We feel really good about it. But in reality, it's more complicated than that. And I think we're now to the point that we can do better. And what this shows is, patients who are on standard of care with high doses of prednisone don't feel as good, right? So the SF-36 kind of demonstrated patients have more pain, have more fatigue, have difficulty ability of doing things, right? Look at the general health perception is actually negative in the prednisone group versus positive in the avacopan group. So it shows that, what steroids are probably doing to patients. And I think that now that we can target the disease much more accurately and precisely, that I think we're going to do better and better. And it's not just about, saving their life, which is obviously critical, but now we can actually do it with less medications that have much more globally deleterious effects. So in conclusion, we went over the complement system. The mouse model data pointing to the alternative pathway and C5a as the primary driver. I didn't really talk that much about the human data demonstrating complement activity, and I ended with the trial data blocking C5a receptor. So I think it's kind of a new world in ANCA vasculitis, and I think it's just kind of incredible where we came from a not thinking complement was involved at all to mouse models kind of really leading the way and showing the path that that C5a is a major driver of this disease. And they may be able to target it very precisely. I mean, how even in much more common disease like rheumatoid arthritis, we can't really say we can do that, right? Where we can block a very particular part of the complement system and really knock this disease out. We also do it really rapidly. And in the preclinical data, it shows that the C5a receptor antagonism is stopped within like 2 hours of starting the medication. So it does it very rapidly, which is exciting because we don't have a whole lot of drugs that work rapidly in rheumatology in general. That's why steroids have been our go-to for so long because we knock out the inflammation very, very rapidly. So it's an exciting time, and we learned a lot. I think it's kind of the first step in, I think, where complement inhibition is going to go in the future. I think we're going to have it's going to be used a lot, not necessarily this drug, but various complement inhibitors are going to be kind of used in a lot of diseases. And we have diseases that we know complement's involved, and ANCA is a disease we didn't think complement was involved, and now we're the first one utilizing it the most. So it's interesting and exciting time for treating it. So thanks for listening this late on a Saturday about complement.